All right, we're back. Advanced Central Perfusion Part 5. In addition to these 5 parts, I also have some older videos, things that I've recorded in the past, basic ECG interpretation, the medications and so forth. So if you have the time and you're studying for your exam, just play them in the background while you listen. So sick sinus syndrome, right? So oftentimes these patients will have a Brady tachy. I'll have an additional slide that I didn't give you in the real PowerPoint just for clarification. So you can take a screenshot or take a picture or whatever of that extra slide. So it's alternating periods of tachycardia and bradycardia accompanied by a long sinus pause. And what we have here is a sick SA node, right? As we get older, things start breaking down and the SA node is no longer doing its wonderful job of keeping us a regular rhythm, right? So if we have pauses, which are literally skipping beats, and we have some tachycardia and bradycardia, we can have changes in the patient's cardiac output. And it happens so quickly that patients don't have time to compensate. So this can be accompanied by syncope or fainting, fatigue, forgetfulness. General causes are anything that can cause a sick heart. So coronary artery disease, just being older, SA node trauma from surgery or, who knows, a contusion, neuromuscular disorders, an MI, rheumatic fever, inflammatory heart diseases. So anything that can hurt your heart can hurt the SA node, and then we end up with a sick sinus syndrome. So for acute treatment, we would put in a temporary pacemaker until the underlying disorder resolves, or if it doesn't, then we may have to put in a permanent pacemaker, or we can treat them with DIG or Inderal. And it's one of the main reasons why people receive a permanent pacemaker is because of this disorder. So here's a classic strip where you'll see, and this can happen in no particular order, this is just the snapshot in time that we took. We have a tachycardic rate. How do I know it's a tachycardic rate? Well, I would count all the tiny little boxes in between the top of the Q waves, or the top of the QRS complexes, and divide that into 1500, and then I would have the actual rate. So we go from a tachy rate, and then we have a pause where things kind of reset, and then you'll see it goes to a bradycardic rate, much, much slower. During that pause, there is no rhythm, there's no pulse. If you were palpating or auscultating this, you would hear beep, 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 nothing. You wouldn't feel anything, you wouldn't hear anything for that short period of time. And patients do report feeling palpitations, or I feel like my heart skipped a beat, which it did, and then it goes to a lower bradycardic rate. So you can see how this doesn't give the patient time to compensate. If they're standing and they go from this tachy rate to a pause to bradycardia, that's going to adjust their cardiac output, and there's going to be a decrease in cardiac output, meaning less blood to the brain, and they may feel woozy or dizzy or even pass out. So now we have the atrioventricular conduction blocks, right? And what that means is that there's a delay or a block in the transmission from the sinus impulse flow. There's some miscommunication between the SA node and the AV node. And this is associated with a prolonged PR interval. Again, anything that can make your heart sick can cause these conduction blocks, right? So ischemia, prior MI, rheumatic heart disease, congenital heart disease. Sometimes we do this with meds too. So ditch toxicity. If we have a metabolic disorder like hypothyroidism, hyperkalemia, or hypoxia, so our patients who are in severe respiratory distress can also go into an AV block. So the first one we're going to talk about is the first degree AV block. Now, in terms of severity, I want you to think back to when you were a kid and you learned about burns. Remember first degree, second degree, third degree burns? Well, same thing here. First degree, it's not that big of a deal unless the patient is symptomatic, right? So really all that's going on here is that the PR interval is greater than 0.2 seconds. I know we don't use trailing zeros in nursing, but I want you to remember it's 0.20, so 0.2. So PR interval is greater than 0.2 seconds. And then that's it. That's really all that's happening here. Most patients are completely asymptomatic. That may even be their norm. If, however, they're symptomatic, we're always going to look at our patient. You can have normal sinus rhythm, and if the patient is showing signs of impaired cardiac output, we're going to treat the patient. But in this case, we're not going to run, I'm not going to run and get the crash cart if my patient is in a first-degree AV block, all right? If they're bradycardic, we're going to give them atropine like we would on anyone on the bradycardia algorithm on our ACLS meds, all right? The second one that we're going to talk about is a second degree type 1. So here's where it gets tricky, and people, nurses I've worked with for years mess these all up. So there's only one type 1, okay? There's 2 different types of second degree heart block, and they have multiple names. Why? Because doctors love to name things after themselves, and 2 different doctors coined the term for this first one. So it's second degree AV block type 1, which is also known as a Mobitz 1 or a Wenke block. I told you it. So this particular heart block has 3 different names. The one you should really memorize is second degree AV block type 1. But for clarification, often on testing or in the NCLEX, you may see the terms Mobitz 1 or Wenke block. You're going to hear those terms spoken in cardiology units all over the United States. Those terms are used interchangeably, okay? So some great ways to think about this is going, gone, or walking away with them for Wenke block. So let's start at the very far left of our strip, and you'll see a pretty little upright P wave followed by a narrow QRS and a T wave. Perfect, we love it, it looks beautiful. And the very next P wave, you'll notice that the distance between the start of the P wave and to the beginning of the QRS has lengthened slightly. If you measure these out, you'll see that they are different. They're progressively getting longer. If you go to the third set, you'll see the P wave is even farther away. Then the QRS, the T wave, and then you'll see the P is we dropped a QRS. So going, gone. It doesn't have to happen with 3 beats and a missed beat. Sometimes it's going, gone. But what's nice about this rhythm is it's predictable, right? So again, I would be concerned if my patient was symptomatic, if I had issues with cardiac output as evidenced by decreased blood pressure or syncope or chest pain. If my patient says they're not doing well, then I'm going to act accordingly. But if in the absence of any symptoms, if the only thing I have is this, I am absolutely going to inform my physician or my PA or whoever the advanced provider is that we have this on the monitor, but I'm not running for the crash cart, okay? So usually we're going to just eliminate the cause. This could be from an electrolyte imbalance. This could be medication involved. So we want to eliminate the cause and fix this. Obviously, if this is causing a bradycardia to the point where the patient is symptomatic, we're going to follow the algorithm in ACLS for symptomatic bradycardia, just like we would with any other patient, all right? Now we're going to go to second degree type 2, which is also called a Mobitz 2. And with this one's scarier. So we're moving up the chain, right? So this is a higher number, and this is more serious. So what happens here is you'll see that randomly or irregularly, we'll have a dropped QRS complex. So we'll have a P wave with then nothing following it, which means that the ventricles don't contract. So we're losing cardiac output here. More importantly, though, is there's in many cases, there's no rhyme or reason. We just randomly may not have a QRS complex, and it can occur in bunches. So we may have 3 P waves in a row with no QRS. So this is more significant, it's more worrisome, it's more likely to lead to a type 3, which is the worst kind. So I would definitely be very concerned with my patient, do a good workup, I'm going to be assessing for things like chest pain. My patient may feel this. If they're hypotensive, so they're showing signs that this is affecting them, we may do a pacer. We would definitely follow the bradycardia algorithm, and we, may even give them more advanced medications. Okay, so this one's more serious. The other thing that, speaking, from someone who looks at strips all the time, it's kind of cool when it happens. It's kind of a, oh wow, look at this, because sometimes it shows up in patterns. And we call that regularly irregular, meaning that it may skip 2 and then 2 normal, or it may have 3 normal and a skip and then 3 normal and a skip. Usually you see some sort of pattern, which is why we call it regularly irregular. It's not great for the patient. The tele staff get really excited because it's fun to see on the monitor, but usually we have an impaired patient and we want to make sure that we're following our bradycardia algorithm. All right, now the third degree. This is the big one. This is the worst one. And what happens here is there's a complete miscommunication between the atria and the ventricles. They have no communication electrically. So when that happens, the atria fire off at their intrinsic rate. So that's anywhere from 60 to 100. And then the ventricle, lacking any direction at all because it doesn't receive any electrical impulse from the atria because it's completely blocked, starts firing at its own intrinsic rate, which is usually, 20s to 40, so low. So the atria and ventricles are not coordinating electrical activity. So this leads to complete blockage of all activity to the ventricles. So when the ventricles have to do things on their own, they do it slowly, usually, but they do maintain a regular rhythm. So you'll see there's no rhyme or reason between the P wave and the QRS. If you measure these out, they vary. They're not in any kind of pattern. So what we'd do is we would count the number of QRSs. So the patient's heart rate is actually about 30, which is low, right? We don't like a heart rate of 30. It's usually not associated with a long and healthy life in an adult patient. The other thing that you want to see is that the P waves can be buried within the QRSs. Because they're not communicating with each other, they can just show up randomly whenever. So treatment would be to usually a pacer temporarily, and then we would treat with, medications. If their cardiac output is inadequate, then we may give them atropine or isoprel. Okay, so a lot of you have heard the term, I'm sure, bundle branch block, especially when we're talking about things like an MI or acute coronary syndrome. And you might ask yourself, well, what is a bundle branch block? So for you newbies, you're not probably going to be able to tell which side is affected. Is it a right or a left or a hemi? What you do need to know is that all of them occur with a longer than normal QRS complex. So what's our normal QRS complex is anywhere from 0.04 to 0.1, right? So 0.04 to 0.1. And if it's greater than that, so greater than 0.12 or greater, then we're going to seriously suspect a bundle branch block. I don't know if you've listened to my other lecture that I have posted for review about basic ECG interpretation, but when we look at an EKG, we're really kind of mapping the electricity's walk through the heart. I hope that makes sense to you. And then it's an average size adult, that walk should take a certain amount of time and should take a specific route. We're not looking for detours. What's happening with a bundle branch block is there's some kind of blockage, which is why we call it a block, in the electrical walk, and it takes a detour outside of its normal path and then resumes the walk later on. So the walk takes longer. The electrical impulse takes longer than it should to get the set distance it's supposed to go. So all we're doing is we're going to look at a 12-lead EKG and we're going to see where the detour occurred. Was it in the right bundle branch or the left bundle branch? So where is the detour? Where did it happen? All right. So we can have an MI. So that's what the one we're really worried about. If you have a brand new bundle branch block on your ECG when you didn't have one before, we're going to seriously consider the patient may be having an MI, and that patient's going to get worked up. Okay. Valvular disease, congenital abnormalities, ventricular hypertrophy, right? So we want to treat the cause and we want to be alert, right? We could end up having a complete heart block. So we could end up having a signal that starts having to do a detour and makes its destination to one that isn't even able to get around the block, right? So we're going to watch this very carefully, especially if it's brand new. There are people that have stable chronic ones that have been documented, and of course we're going to watch them too. But you really have to be careful if you see a brand new bundle branch block. How do we know we have one? Well, we would look in a lead 2 if we have a QRS complex that's too long, greater than 0.10, then we're going to see, if that's brand new, we'd let our physician know, they would get a 12 lead. And then looking at the V leads, depending on where you see it, you would then determine if it's a left or a right bundle branch block. Junctional dysrhythmias. So if the SA node is too sick to do its job or has been damaged, then the AV node will take over. Okay, so the AV node then becomes the pacemaker of the heart. Unfortunately, because remember, we're taking our electrical walk through the heart, the AV node is much closer to the ventricles than the SA node. So because of that, we're going to see a difference on our EKG. And it could be anywhere from a missing P wave altogether, so there's no P wave, or we may have a negatively deflective. So in a lead 2, remember we have an upwards positively deflected P wave. We may see a negatively deflected P wave where it's upside down, or it could be flat, or it could even occur after the QRS complex. So it's not going to be a perfect upright QRS complex. That's between 0.12 and 0.2. It's not going to fall within those parameters. So that's why we do those measurements. So if you see no P wave and a normal narrow QRS, or you see a negatively deflected P wave in a lead 2, or the P wave occurs after the QRS, then we would suspect a junctional dysrhythmia. The intrinsic rate of the AV node is between 40 and 60 beats a minute. So that's another clue. If you have a patient whose heart rate is around 45, and then you see a negatively deflected P wave, you would suspect a junctional dysrhythmia. Now we have something called paroxysmal supraventricular tachycardia. So how do I know if something's paroxysmal? I can never say this word. I'm going to say intermittent, okay? So how do we know is paroxysmal means intermittent. So it doesn't, it comes and goes, right? And then supraventricular just means above the ventricle. So we have skinny QRSs. We don't have wide and bizarre QRSs. So it's an arrhythmia that originates in an ectopic foci anywhere above the bifurcation of the bundle of His. What does that mean? Is that there's some angry rogue cell in one of the atria that has become the pacemaker for the heart and is firing at a really, really fast rate. Okay. Then we have something called a reentrant phenomenon. So the kind of like a domino effect, where the electrical impulse kind of goes around and around in a circuit and it beats really, really fast. All right, so if we have a heart rate greater than 150, and in some textbooks you'll see that number is 150, we may have decreased cardiac output. So if we see this on the monitor, we see a very fast tachycardia, we're going to assess our patient. And then if they have a pulse and they're symptomatic, we're going to follow the tachycardia with a pulse medication and defibrillation algorithm. All right, so here's a nice mnemonic, A-E-I-O-U plus D. So if your patient is having an arrhythmia, we want to start with autonomic nervous system. Remember, we have some natural responses. The sympathetic nervous system, fight or flight, will kick in, and that increases heart rate. So we want to check for things like pain, anxiety, and stress. All right. We also have the parasympathetic response, which is that vagal or rest and digest, and that decreases heart rate. All right. So we may have a patient who's bradycardic that has an increased vagal tone. Sometimes from bearing down in the bathroom, having a bowel movement can cause a bradycardia. Patients who have lower abdominal pain and they're kind of guarding, that can also cause bradycardia. Even though they're in pain, it's because of where it is. We also want to watch for acidosis and alkalosis. E would be electrolytes. So we want our potassium levels to be within normal, right? So with cardiac patients, we give them so many medications that affect potassium. We want to keep them at a healthy 4.0. Calcium, remember calcium is involved in muscle contraction, so we want to keep them within a healthy range of 8.5 to 10.5. And our magnesium as well, 1.6 to 2.2 milliequivalents per liter. Now, again, with cardiac patients, we want to keep them at a healthy 2.0. I would be ischemia, injury, and infarct. If a patient is diagnosed with acute MI or acute coronary syndrome, we would watch that ST segment, the T wave, and the Q wave. And dysrhythmias, especially ventricular in nature, are commonly associated with an acute myocardial infarction, also called an acute coronary syndrome. Oxygen, hypoxia. So if a patient is diagnosed with an acute MI and we see EKG changes in the ST segment, we're going to make sure that we're not dealing with a hypoxic patient. We want to supplement with oxygen. I think my slide's a little off. So O is for oxygen. So hypoxia can cause a dysrhythmia. So I want you to make sure that your patient is adequately oxygenated. U, unhealthy heart. So could we have heart failure or valvular disease, cardiomyopathy, renal disorders, hypertension, or pulmonary disorders? And D stands for drugs, right? So not just the things that are on this list. Know things like caffeine, which caffeine actually blocks the effect of adenosine, which is something that's our body's natural braking to slow down a tachy heart. Our body will kick out adenosine and it slows the heart like a little tap on the brakes. Well, caffeine blocks that effect, so you can have tachycardia from that. So it isn't just drugs that we administer to patients. They can be self-administered as well. So cocaine, other common over-the-counter, or illegal counter medications too. Digoxin and beta blockers can lower our heart rate and cause a bradycardia or a bradyarrhythmia. All right, so diuretics, if we're lowering or adjusting the patient's fluid volume, that can also impact. And remember the effects of loop diuretics, especially on potassium levels.